In this half, Dr. Roswright will talk about social determinants, followed by Dr. Aurora talking about his new teeth biomarker to reconstruct past exposures. So this first talk is Dr. Wright, why social determinants are critical in the exposome framework, risk and resilience.
Okay. I think another unique aspect of our center is that when you think of people that are trying to do exposomics, many people are focused largely on the external chemical environment and the pollutant environment. But we also think about another important aspect of our environment, which is the social environment and the emotional experiencing of that environment, and how that may actually interact with these chemicals, but also have independent effects. And it's also an interesting aspect of doing exposomics because there's opportunity for building resilience and intervention. So again, just to reiterate what others have said, the Exposome Institute is really about comprehensively assessing all of the environment. And even though, as Megan pointed out, we're never going to do it all, but just to get any step closer to linking these things together. And what I'm going to talk about today is how stress might play a role. And I use this tree and talk about the root causes of disease because we start a lot of our work in the prenatal environment and think about pregnancy and what women are exposed to in pregnancy and what they carry into pregnancy that might have health effects not only on the mother but the next generation. And this isn't necessarily a new idea. I mean, back in the 70s, there was a book written by a psychologist, Raising Children in a Socially Toxic Environment, already thinking about social toxins, things like growing up in chronic poverty, violence and crime exposure in your communities, in your homes, economic hardships, and chronic experiencing of racism, discrimination. Thinking of these as social pollutants. And there's a lot of literature that's come out that shows, and some of the work that we're going to show that we do, social toxins are as detrimental, if not more so, to these chemical and physical toxins that we've talked about with health and development. And not only do they have independent effects, but we don't live in a bubble. We're concurrently exposed to these things, and there's actually good evidence that there's interactions between the chemical and the non-chemical social stressors. So this is sort of the way we conceptualize it when we develop our longitudinal cohort studies or use registries, et cetera. We think about how can we rigorously go after all of these components of the environment that we thought at the time that we developed this particular study we could measure very rigorously. So we went after air pollution in the way that Alan just described earlier, tobacco smoke exposure. We went into the homes and measured allergens and quantified it by collecting dust samples. We look at diet and nutrition, what mothers are eating during pregnancy, but also the children as they develop. And then the social environment and how you emotionally experience that through psychological stress. And over the years, those bubbles have changed where they rotate around this infant's head, because in my career, I think stress in the social environment has really bubbled up to the top. It's one of the biggest drivers of health and development, and it's one of the biggest levers, I think, for building resilience. And we're going to talk about how stress gets in the body and how you emotionally experience your environment can actually get in, just as when you inhale other pollutants and things like tobacco smoke. Because when you experience something cognitively and it outweighs your ability to cope with something, you start to feel emotional distress and negative affect from that. And that triggers release of neurotransmitters and hormones that are released down into the body systemically, and it ends up having your body produce chemicals like adrenaline, so that you can feel your heart rate go up when you're nervous or anxious. You can feel the hairs stand up on your arm or the back of your neck. You could sweat a little bit, feel nauseous, these kinds of things. That's because your body's making adrenaline. in the context of stress. But then it interacts with other systems, and you kick out things like cortisol or hormones. We always hear about cortisol as a stress hormone. These things talk back and forth to other key regulatory systems, your immune systems. So you might, if you're under stress, you may be more susceptible to infections. That's an evident, obvious way that your immune system predisposes you to chronic or health problems. And we want to get you back, when you have things in your environment pushing and pulling on those systems, they put you outside of an optimal balance, and that's where you start to get adverse health effects. So that's the biology of stress. There's some optimal balance, and when you tip over that hill and you either have too many stressors, high magnitude stressors, or you just don't have the coping capability, that's where you start to experience disruption of these key regulatory systems and chronic problems. Now, when the mother carries that into pregnancy, either from her past experiences or what she's experiencing now in pregnancy, it gets transmitted to the infant. And what's happening to mom in those key regulatory systems already is starting to program what's going on in the infant, setting them up, trying to get them ready with what the body thinks is going to be their environment. But there's going to be a detrimental cost to that potentially, unless we can recognize it early and see if we can't get that kid back on track. And we'll talk about some of the ways we're thinking about that as well. So just like when mom smokes, as shown in this ultrasound, and the baby's smoking, stress gets in the body just like cigarette smoke, and we know that. We can picture that. And you got to think about stress in the same way. So why do we care about it in the exposomic framework? Well, there's good evidence that there's independent impact of psychological stressors that you experience from your environment. And one of the ways that we measure it is through survey measures of cumulative stress. So we ask about experiencing stressors across a number of life domains, and we use different measures for that. And this just gives you an example. So if you have a mom in pregnancy who says, gee, I'm experiencing a lot of financial strain, I also have chronic racism, discrimination, relationship problems, including interpersonal violence, either in the home or in the community, and other negative life events like housing, these kinds of things. You can imagine in your own life, you're unable to cope with stress when it all piles on, when you're experiencing it across lots of these different domains. So we just add up the number of life domains that mothers are experiencing stress, and actually we find very strong dose-response relationships. This graph just is, showing the relationship between increasing number of stressors that they're experiencing across domains, either during pregnancy or in the first 2 years of life of that child. And what I want to draw your attention to is there's a straight line here. It increases in a dose-response way. So the more number of life, domains that she's experiencing stress, her child's at increased risk of developing disease. In this case, we're looking at an early marker of asthma, wheeze, in the kids. We could follow these kids out, and we have for a number of years after birth, and show that they're at risk for increased asthma and also lower lung function, more obesity, neurodevelopmental problems, etc. And this just shows that the particularly at risk are the ones that have high levels of stress in both the pre and postnatal period. So cumulative exposure. So even if mom's experiencing stress in pregnancy and you get them later, you can still intervene and have an effect on the health of the mother, but also it has implications for the child's health. And this shows that not only at risk for asthma, but if you measure an objective measure like lung function in a 7-year-old in the context of this, again, if mothers experience lots of stress in the early postnatal period, they had much lower lung function that we measured. Why is that important from a life course perspective? Because I'm a pulmonologist, so I know if a kid by age 6 or 7 has lower lung function that we measure at that point, it tracks the rest of their life. They're going to never achieve the maximal level of lung function they're supposed to when those lungs stop growing in late adolescence or early adulthood. They're going to lose their lung function much faster, and that's a risk factor for early morbidity or mortality. It's a risk factor for cardiovascular disease and chronic lung disease and other things. So we're already putting that kid behind the 8 ball as far as the health trajectory they're going to experience over their life. So early life toxic stress literally is taking our breath away. We go after mechanism, and what we've done so far is similar to what Bob Wright was talking about at the beginning, is we measure one thing at a time, and this is the way science was. You're reductionist, you're looking at one mechanism at a time, and we have demonstrated that chronic cumulative stress, like I talked about in those other results, also disrupts HPA axis or cortisol production in these mothers. We've linked that to, you don't have to know the details of that slide, but basically this paper just showed that mothers who had disrupted and higher levels of cortisol production in pregnancy, their kids who developed in that milieu were much more likely to go on and develop asthma, lung disease, and lower lung function. We've also linked it to immune imbalance, so in the infant at birth. So mothers who experienced higher levels of stress during pregnancy showed a dose-response relationship with decrease in production of certain cytokines or proteins at birth, which is a marker of increased risk for chronic inflammatory diseases going forward. This is at birth, cord blood, isolated at the time the babies are born. They've never seen the external environment, and already their immune system is not optimally responding to that environment. Now, that's important. It's good to know and reduce it down, and that evidence base shows that, yes, it's getting in the body and disrupting, but what we really need to do is what Megan Niedzwiecki was talking about and take a much more untargeted, broad approach, right? Because we want to understand across all of those systems, not one at a time, but how are they interacting and what's that optimal balance that we're trying to achieve? What fingerprint says risk, what says resilience, and how can we actually harness that and take that information, prevent problems before they develop clinically. By the time I see a patient and diagnose something clinically, they have symptoms, it's gone on for quite a while, and it's, you know, we want to catch them before they develop clinical disease and prevent, and that's really what we're trying to do. Life course versus current. So that's telling you experiences of stress right there during the pregnancy. Yes, that's important, but it turns out that we also have to know where that mother came from. What was her life like when she was a child, even during adolescence, during adulthood, prior to that pregnancy and the pregnancy. One way people have gone after the social environment is because it's relatively easy for people to recall their socioeconomic status during their life course, and with things like something as simple as did your parents own their home during different life stages. That's something we can remember. I can't remember how much money they made at a certain time. But I do know whether or not they owned their home. And it turns out that childhood SES of the mother is independently predictive of her health at the time of pregnancy and outcomes, but also it gets transmitted to the next generation. So there's a group, this is data from the University of British Columbia, Michael Kobar and others, and they actually looked at home ownership as a marker of maternal socioeconomic status or earlier life socioeconomic status predicting current disease. What they showed is that this is a study of 1,000 medical school graduates. These happen to be all males, and they were looking at cumulative probability, following them from medical school onward, characterizing their childhood SES, and if the kids who had lower childhood SES, independent and controlled for current SES, were much more likely to have cardiovascular disease as they followed them over time. And that's actually, that's important to understand. There can be interactive effects, there can be pathway effects of that, but really more and more studies are finding that there's independent effects of your own childhood SES as you go on. There are things you can do to minimize that risk, but if we don't recognize it, we're not going to minimize. It gets laid down. This shows you that if you look at changes in your DNA, epigenetics, how the environment changes how your genes are turned on and off. It's again, if you compare in that cohort, current SES when they're 30 to 40 years of age versus early life SES between the ages of 1 and 5, the early SES is much more significantly related to these changes in your DNA. It gets embedded, even at a fundamental level. We've actually associated maternal childhood SES to risk for asthma. Again, you don't need to read the whole graph, but what we showed here is we looked at how maternal childhood SES adjusted for current SES had independent effects on risk for asthma and lung disease in their offspring. We also showed that cumulative exposure of lifetime trauma in these mothers was the most powerful predictor of increased immune disruption at the time of birth in these kids. So moms who experienced abuse in childhood and interpersonal trauma, say in dating relationships in adolescence, or domestic violence as an adult prior to and including the pregnancy, her children had much more disrupted immunity at the time of birth as well. So you need to understand not just what she's experiencing now, but what her life course has been as well. I'm just going to skip that because the next thing I want to underscore is why it's important in the Exposome Institute, is that stress interacts with the chemical exposures that we typically think about, and that's the people that are most at risk, that have concurrent exposures to both stress and the environmental toxins like air pollution. So you heard Alan just talk about the models where we can get daily measures of air pollution from conception to delivery. So we're looking at pregnancy in these women. And what we're looking at is if you're over this dotted line, over 0, that's the period in pregnancy where higher exposure to, in this case, traffic-related particulate matter, air pollution, that we get from those models that Alan was telling us about, there's an increased risk of asthma when you follow these kids out to age 6, 7, or 8 years of age. That's interesting. But then you stratify by moms who had low levels of prenatal stress based on the number of life domains experiencing negative events versus high prenatal stress. And it's only in the high stress group that we actually see the impact of the air pollution. So then you can actually get a better understanding of the group that's at risk and understand how you might intervene around that. What this tells me as a public health researcher is that if we intervene to normalize stress in those mothers during pregnancy, even though maybe it's going to take us longer to change policy and traffic patterns and air pollution levels, we can actually mitigate the effects of the other toxins in our environment. The other thing is that we think it's important, it's a lever to build resilience. If we can understand what factors in your social environment actually protect you or actually enhance positive health, that would be a good thing. And one thing we're finding that is we're focusing on a lot is maternal caregiving, because there's no stronger social environment in a newborn up to age 5 than the nurturing care of your primary caregiver, and most of that time it's the mother. Quality of care, if it can actually mitigate the effects of chemical toxins as well as those social stressors that we're talking about. And we're trying to disentangle that in the lab. Bob mentioned the PACER lab, the Physiologic Assessment of Children's Environmental Risk Lab. Here's where we bring our moms and infants in that we've already characterized all those exposures out in the field. And we do a laboratory challenge, and this is how we set it up. We just put the kid in a car seat, we hook them up to cardiorespiratory monitoring, mom's hooked up to these things as well, and we're videotaping as we do a challenge. And so we measure them at rest and play, and then we do a stress challenge. We get a little bit of recovery period, stress them again, and a recovery period. And that's basically what we're looking at. And during that, we're measuring how upset does the kid get through different negative affect measures. We measure their heart rate response to that, how much of the adrenaline versus putting the brakes on that happens during that stress challenge or the recovery period. And we also measure cortisol, so we can get that from their saliva. So we put a little cotton roll in during the stress challenge. We also use that video camera to videotape them, and we can actually rigorously code, and we have child developmental psychologists who've helped work out the ways to do this, and we can characterize sensitive versus insensitive caregiving, even during a 10-minute laboratory challenge test. And actually what we've been able to show, and we've published these data, is that moms who have cumulative higher levels of stress, their infants have abnormal reactivity to that stress challenge and are less able to recover during that recovery period. But it's the ones in the dotted line that also have insensitive caregiving behaviors that we're able to monitor with those video cameras. They have much more sympathetic outpouring. This is a problem. This is at age 6 months. That's a big risk factor for cardiovascular disease, cardiometabolic disease, risk for diabetes down the road. Sensitive caregiving. So if we can give people tools, build that in, we can actually buffer them from developing that. This is their cortisol response. Same thing, dotted line, higher levels of cortisol in those kids. We don't want to see that. That is not optimal balance of that regulatory system. So maternal sensitivity buffers negative affect. Maternal sensitivity buffers activation of the ANS, so the autonomic nervous system, cortisol output, despite distress, that's normal, and need for caregiving interventions in infancy and early childhood. So this is something we're developing interventions as well as risk. So in summary, socially toxic environment, it's not simply a marker of more toxic physical environment. I know they track together oftentimes, but we're really going to tease them apart and look at synergistic effects. Social context and consequent stress may be as detrimental or more so to children's health as chemical toxins, and it enhances the effects of these chemical toxins, and through stress interventions we can mitigate effects. And sensitive caregiving may be a major way to do that. So thank you very much. Now we're going to have Manish Arora come up and with the anchoring talk, and then hopefully you're writing down your questions on your cards. I know we're getting some of those sent up, but please go pass those on to Megan.
How does this work? Great. Thank you very much, Dr. Wright. So, first of all, I want to start off by thanking those members of the audience who sent me some emails over the last few weeks in anticipation for this. The common themes and the questions that arose were, they wanted to understand the role of the environment among the major players in mortality. Cancer was one of the items that I got the most emails about, cardiovascular disease, and also ALS. So let me start off by giving you a very strong and clear answer about those questions. So this is data from a very large study undertaken in Europe. And what you see here is all the major killers, the cardiovascular disease and the different cancers that impact almost every developed country. The lines in blue are the environmental contribution. The lines in red, or the part of the bars that is in red, is genetics plus shared environment. It's not genetics alone. And let me tell you that the least environmental contribution to all these major diseases is 80%. So 80% or more of the factors that drive these major killers are environmental. So there is no doubt that the environment is the big piece. Like in the very first talk, Dr. Robert Wright said, unlike genetics, the environment is not a finite quantity. I'm going to share with you the complexity of just one small component of the environment to convey how complex the environment really is. I work in the Senator Frank Lautenberg lab. What he tried to achieve was regulate various chemicals that are introduced into our consumer products, focusing on children's safety. Some of these numbers are old. Here we see that there are 84,000 chemicals. That's old data. We have well over 100,000 chemicals now. But the numbers that have not changed much are what the FDA, our government is able to regulate and test to a high level of scientific evidence. But it's not just this problem has 100,000 different components. It's not a static problem. Dr. Wright, earlier in his very first talk, said when is just as important as how much. And you would have seen, many of you would have seen this famous cover of Time magazine saying that the first 9 months of life shape the rest of your life. Because it's not just that you're getting exposed to thousands of chemicals, it's when you get exposed to it that's very important. So let me give you some real data on why that is important. I'm going to focus on fetal development. So here's a study that quite simply did MRIs of a fetus, a human fetus, during different stages of development, from 13 weeks in utero to the 21st week. And the graph on the lower right side shows an increase in thickness as a global measure of what is happening, the complexity of the networks forming inside the brain. What you notice is that in this 8-week period, the density of the brain has quadrupled. It's increased by 4 times. So the take-home message here is a lot is happening, and it's happening very quickly. But the problem is actually even more complex than that. If you walk 50 meters outside this building and stand on Fifth Avenue and take a deep breath, and you come into this room and take another breath, what you're inhaling are very different exposures. Our exposures change over small periods of space and time. But our ability to deal with those exposures also changes as we progress from our fetal development into childhood and into later life. What we are exposed to and how we react to that as a fetus is very different to how we react to that as a child, and to the same exposure, how we would react to that as an adult. But often the same exposure can have very different impacts even at the same age. Let me give you a very simple example. Last night I was watching the women's ice hockey team. My sister is married to a Canadian. For the first time, I'm really excited by that fact. So as soon as the game finishes, I text USA, USA. Don't ask me what my passport says. That's a detail I'll ignore for now. And the reaction my niece would have, who's very Canadian, would be quite different to the reaction I'm having. So the same exposure can have different impacts on people at different ages. I'm trying not to make eye contact with one of our Canadian postdocs. But here's the thing. Things are changing so quickly. But look at your own personal experiences. You go to the doctor, they draw a sample of blood, they send it to a path lab, and for whatever they're measuring, you get one number, you get a snapshot. And my problem with that is not just that you get one number, that the range around it is ridiculously large. But I won't go into that. Let me give you a simple analogy why that is a problem. Now that we know that the environment changes, our physiology changes, then why is a snapshot a problem? Let me give you an analogy. If I showed you a picture of some cars like this and asked you the question, how fast are they going? That would be a very difficult question to answer. But that's kind of what we are trying to do with a single blood test, to figure out what's happening to you over a long period of time. And the question is even harder for us. It's like looking at that picture and saying, how fast have each of those cars traveled since they were manufactured, since they were in their fetal development? That is not the right way to understand the environmental impacts on health. So we asked a very difficult question. In fact, I would say this was one of the most difficult questions in environmental sciences at least 10 years ago. What were you exposed to before you were born? And it's a question I want to ask all of you. Can you figure out what you were exposed to? Because if the Time magazine cover is correct, then your fetal exposures are affecting your health today. But can you figure out what your exposure was quantitatively, objectively, before you were born and in early childhood? So this is what we started working on more than 10 years ago. And the idea was very simple. I call them biologic hard drives. Think of a tree that's been cut cross-sectionally, and you see growth rings in it. And we've been making assumptions from those growth rings, even from very rudimentary measures. You see a thick ring, you assume that rainfall was good that year, the tree grew well. You see a very thin ring, something stunted the growth of that tree. Perhaps it was a drought. That is a very simple form of a hard drive, that is collecting information in an incremental archive. Teeth also have those same growth rings. They're linked to our circadian or day and night rhythm. So today all of you are forming a ring in your teeth that's capturing information about what you eat, what you drink, what you breathe in, what you're exposed to, all the medications that you might be taking, and also emotional and social stressors, chemical signatures of those. This is old data. What I want to show you is the trend, and I want to show you how we are applying this technology for a public health problem, a high priority public health problem. We all know the prevalence of autism is on the rise. Back in 2009, where this graph ends, it was 1 in 110, and now we're hovering around 1 in 50, 1 in 60 in most developed countries. So we know autism prevalence is increasing. We've invested an enormous amount of effort in understanding the genetics of autism. But like Dr. Wright says, if the prevalence is increasing over such a short time period, about 40 to 50 years, it's not going to be genetics. And guess what we found from a large amount of that genetic research? That it's not an identifiable factor. We still don't have a test that can measure your genes at birth and say, yeah, you are at risk of autism with any degree of real certainty. I want to take some time to go through this graph because this is about 7 years of effort. If you look at the bottom axis, it will say Sweden, US, New York, US, Texas, and UK. So this is a study conducted across 3 countries. I like to joke that it's actually 4 countries because 6 months ago when I visited Texas, they insisted that they were their own country. But that's okay. Like I said, we won't discuss what my passport says, so I feel I don't have the right to get into that discussion. But the black circles that you see, they are controls. And the orange squares you see are the cases of autism. You don't need to understand what we are plotting here. All you need to do is imagine a line drawn around 3.6 or 3.7, and you're separating the cases from the controls. And it doesn't matter which country you're from. The cases are from UK, you can compare them to the controls from Sweden or from New York. You will still separate them pretty well. So this was an enormous effort, an enormous international effort. And we used all this data to develop a classifier. A classifier is the first step towards a diagnostic test. The reason we did that was all of this information is coming from the prenatal period and the first 6 months of life. So well before any clinical signs of autism develop. And right now, this classifier operates at over 90% accuracy. So we are very excited about working on this because if we can roll out a diagnostic test early, then the interventions can begin early. Now I want to go to another email I received a few weeks ago. It was about ALS. See, autism happens at the age, or the signs appear at the age of 3, 4, 5. What about conditions where the lag is 5 decades, not 5 years? So this is Lou Gehrig's disease or ALS. We only understand about 10% of the etiology of this disease. We've identified a couple of genetic mutations, but they're not really predictive. There are people with those mutations that never develop ALS. And like with Parkinson's, like with Alzheimer's, we suspect that it's not just the environment, it's the early life environment. Something happens in early childhood or even sooner that changes your trajectory ever so slightly, that around the age of 60 is when you are separated clinically from people who don't have ALS. Again, this is a busy graph. I don't want to go into all the fine details. All of these lines are different chemicals that we have measured. Some are essential elements like zinc and copper that we all need. Some are toxic metals like lead. But don't worry about what the trajectory of each metal is. What you will see, and what is the most important part of this graph, is what's on the horizontal, the x-axis. It says time since birth in years. These are patients who gave us a single sample at the age of 60. We have gone back in time to around birth and up to the first 15 years. And even at birth, there are differences between those who go on to develop ALS But it's amazing to look at our physiology early in life. It almost feels like the body tries to correct itself, adapt to it, and by the age of 5, those differences almost disappear. And then later in life, everything seems to start moving apart in a different and very complex pattern. So it's not just one hit, it's multiple hits. And this is a very early study. I must caution all of you that this is a very small sample size, this is an early study, but this is what this kind of technology can achieve, that we can look at early factors. If this is correct, then we've just got a 5-decade lead on some risk factors, which we hopefully can use to change those trajectories back towards health. But it's not just about preventing disease, it's about increasing health. I just want to end by thanking all these people from our lab and my colleagues, but also showing that we are helping not just around the US. I didn't put any red arrows in North America because the whole map gets covered by red arrows. There are so many studies that we're doing within the US and Canada and Mexico. But we are also the center for studies from many, many different parts of the world. Perhaps the one I'm most proud of is a small study in Mongolia where they don't really have an autism center, and we do all our work with them pro bono. So I'll leave this slide up to thank all the people who have helped, and I'll stop there. Thank you very much.
Great, and we're actually right on time. Please, I have several cards. I see some others coming up. Please pass them to the aisle, and we can bring those up. So I tried to organize these a little bit while we had some time before the others come. So let's start. Some of these were right from the start, and a broader question to Dr. Bob Wright, but with that opening talk. But anyone on the panel also can dive in. Experimental technology improvement was only a part of the reason for the explosion in genomics since 2000. An equally important factor was the embrace of technologies from other areas such as computer science, high-performance computing, data sharing, etc. So what are the institutes or the community's plans for embracing such non-experimental technologies as well, and what's the importance of that to the Institute? And maybe, Bob, you can start, and others can join in. Is it on? I think it is.
It is on? Okay. Yeah, I wholeheartedly agree with that, and in fact, it is the advancements in computational science that were largely driven by genomics that actually make exposomics possible, because it's not enough to generate thousands or hundreds of thousands or millions of data points. You have to be able to analyze it. And so I wholeheartedly agree with that. And in fact, we are leveraging the advances that genomics drove in computational science and exposomics. There are some differences in our approach compared to genomics. As I said earlier, genomics, your DNA is static, basically can measure at any time, and we need to measure environment repeatedly over time. So some of the things that we're doing, which are possible because of high throughput computing, is trying to look at longitudinal changes and measuring environmental factors repeatedly over time and trying to identify critical windows, which is a much different approach than what genetics takes. So we're actually in the business of developing new methods of data analysis, as well as developing new methods of measuring environment. And I should add that one of our interests is in a new field called phenomics, measuring multiple health outcomes or phenotypes. Yeah, it's true that a lot of phenotypes actually predict other diseases, or phenotypes predict phenotypes. Everybody knows that hypertension can be thought of as a health outcome. Well, hypertension also predicts heart disease. So I think some of the things that we're working on is how do we integrate that known knowledge about how health impacts other health effects. So it may be that lead poisoning, for example, gives you adult hypertension, and that leads to heart disease. And if we only study lead in heart disease, we sort of miss that middle pathway, and maybe the intervention can be done in that middle pathway. So we're actually trying to understand health at a much broader level and in 4 dimensions. That is how it changes over time.
And actually, others can comment too on the importance of data science and high throughput computing, I'm sure.
Sure, I would add to that that a key component of the Institute is the transdisciplinary nature of the members. And so technology is a piece. Technology has enabled advances in remote sensing and analytic chemistry, but we also need to use other tools and other approaches to be able to make sense of that. So that's something that Mount Sinai has a particular strength in, and that our institute is rapidly developing as well.
Anyone else want to? We could all say that. I mean, that it is going to be a critical component of what we're going to have to keep growing and building here, and that's been true for the efforts around other omics, whether you're talking about genomics as well. That's absolutely critical. This is really team science. That's the way science is going. We really want to embrace that complexity and be as comprehensive as possible, as Megan said. Can't do it without the computational science. And fortunately, Mount Sinai has really attracted top-level talent in that as well. And that gives us the, that really accelerates our capability of doing some of the things that you've already seen, and that we're hoping will continue to grow as we go forward. Another broader question is to anyone. Childhood cancers have increased. Currently, about 14,000 diagnosed annually. Is there a link between chemicals in the environment and the increase that we're seeing in the incidence of a number of these childhood cancers? And if so, where does that evidence come from? And again, it's a multi-part. If so, what are we going to do about it? Or what are we trying to do about it? And we being the broader than us, but the scientific population or community. Does anybody want to comment there?
So, like I presented in my very first slide, yes, it is the environment. The environment is. Can you hear us? Can you hear me? No? Better now? Okay. Sorry, I have a cold. So yes. The environment is the biggest player for most cancers, including childhood cancers. And this is nothing new. I mean, I showed a really strong piece of evidence. It's not evidence I or my group collected, but still, that is very good evidence, which is why I showed it. And a few years ago, might almost be 10 years, that the president's report on cancer came out, and they listed environmental chemicals as an area of concern for cancer. Well, that's half the answer. Knowing that the environment is important doesn't help you identify what components of the environment are driving that increase in childhood cancer or any type of cancer. And that's what we're trying to achieve. And that's not an easy question to answer, because if you just look at chemicals, our ability to introduce new chemicals into the environment far exceeds our ability to test for their safety. Right? We will never be able to test for the safety under the current rules of play, where the onus of showing that it's harmful lies on us, academia and the community and the government. There are other approaches where the burden of proving safety lies on industry. And I'm in favor of that, because if we had a balance of those approaches, we could balance innovation while making sure that these new chemicals are being introduced into the community in some regulated manner. So to finally directly answer the question, Exposomics, this institute, novel technologies, and a multidisciplinary approach is absolutely trying to answer that question. But we're not there yet.
Just to add to that, one of the difficulties in studying environmental risk factors for cancer is there's typically a relatively long delay between the time you're exposed and the time you develop cancer, which is often measured in years. So if you measure something at the time a child is diagnosed with cancer, the causative agent may be gone, because that may have happened years in advance. So I think one of the things that, as I mentioned earlier, that our institute is interested in is going back in time. So a lot of what Manish does, I think, could be applied in childhood cancers, because the root cause of the cancer is probably not something that a chemical or environmental factor that child was exposed to at the time of diagnosis. It's probably something that happened years in advance. And so I think that's part of the difficulty in studying the environment, why genetics tends to be the focus, is because your DNA sequence never changes and you can measure it at the time of diagnosis and you know that it preceded the disease. But the real issue is probably a gene-environment interaction, and I think now that, with Manish's work, I think we can go back in time. I think the ability to start to look at those chemicals is going to be a little different than it has been in the past.
And some of the GIS methods as well could be helpful in that regard. A couple of questions directly for Megan. So the first question was related to the Petrick et al. Study on the ALL study. The question was a little bit more detail. Was it prospective, and how did they actually collect the blood spots at birth? Was it part of routine standard of care? Did they get historical collections? And go ahead and answer that. And then.
So I cannot answer the specifics about this because this was actually a study that was conducted by one of my colleagues here. But I do know that it was a prospective study where I think it was blood spots from, I think everybody in the state of California possibly. So it's collected on every child. And what were the other?
That was the question, is how were those blood spots? That's my recollection of that study. Mm-hmm. It was the blood spots that are routinely collected at birth for other purposes, but many investigators are trying to go back, and sometimes it's easy and sometimes it's not, and each state is a little bit different. And the state of California was, I believe, you're correct, and that's where they came from. So there's a lot of talk about that. People are developing new methodologies to be able to measure more and more in dried blood spots, because they're just go on to these little paper cards, these Guthrie cards, and they can be stored relatively inexpensively. You don't need to have huge freezers to store all these things, and many things are quite stable on the card, like DNA, but some things require special handling of those cards and processing of those cards. So that requires a lot of science behind developing new valid methods for measuring various things. And the more that, and we do some of that here as well, as we talked about, because Lauren Petrick is doing this in the dried blood spots. That's a very new area in metabolomics to try to take advantage of those. But we'd like to do them for other things as well, so we'll certainly be hopefully advancing some of those methods too. It says in general, it seems like exposomic research in metabolomics requires prospective studies because we wouldn't have normally collected and stored blood, and then go back and look at, is this a limitation of metabolomics in exposome research or a particular challenge?
I do agree that this is a limitation for doing metabolomics in, for example, a plasma sample. But I think I mentioned in the presentation that we're also able to use metabolomics in other samples as well. So I know that there is an interest in our lab in trying to apply metabolomics in, for example, in the teeth. So we can actually do these untargeted assays, and we can actually, through that, try to understand the windows.
Yeah. And then one more for you, Megan. How fast? Oh, I'm sorry. You have some comment on that?
One quick comment to link it to the previous question is every child in America has a blood spot collected at the time of birth. And if you use that in an assay for metabolomics, an untargeted assay for exposomics, that is going back in time to reconstruct what happened to them around the time of birth. So that is a form of going back in time.
Right, where it wasn't prospective, but taking advantage of data that is appropriately banked for some question that you can ask with it. How fast does the metabolome change over time? For example, if we measure metabolome of a cohort every month, what is the intra and inter-individual correlation?
I think that's actually a very interesting question that I am interested in trying to examine here. I don't think that there really have been that many studies that have examined this. I know even throughout the day, there are major changes. So if you collect a sample in the morning, there will be a different profile than if you collect it in the afternoon or in the evening. If you collect it after you have a meal, you'll have a very distinct profile. But I'm not sure exactly how much it changes over a longer course.
I think some of those challenges are being worked out as the field develops. And of course, when you have a prospective study, you can anticipate some of those challenges and try to collect information so that you can account for as much as possible how much that may be influencing the results and how you interpret those results. I think that's important. So marrying a lot of what we do a lot of these prospective cohorts. That's another aspect of our Exposomic Center. We have them at different places. Manish has mentioned some that he's been involved with globally. And we are involved in those as well, and measuring some of these other things and incorporating things like the metabolomics into that. So that would be a strong design to be able to address some of those issues. And then for Alan, there were a few questions. In the 1 by 1 kilometer grid, how do you factor in distance of a subject's home to busy roads? You mentioned it briefly, but maybe a little bit more detail on how to account for that.
Sure. So we know that being very close, very proximal to a big source of exposures, particles like a busy roadway, is associated with a much higher exposure level. And there are methods from dispersion models where you can see that the drop-off of the concentration of particles is quite rapid, quite steep. As you get a few hundred meters away from a major roadway, the number of particles coming from that roadway drops down a lot. So I mentioned that we're using these NASA measurements, which are capturing an average exposure on a 1 kilometer square grid. We do have methods where we go back and in residual, in whatever proportion of the, we can use local monitoring data, and whatever we can't explain with our model from the satellite, we can go back and have a second layer model that's trying to look for those very local effects. And we'll often do that on a 50-meter grid, where we're looking for the role of a major roadway, and that's where geographic information systems are very helpful, because we can use classifications of roads, or if there's available data on traffic intensity, sometimes we can scrape that from commercial sources. But our methods can layer different kinds of information. So we're using both the satellite as a sort of average proxy of what's happening in that area, and then we can layer on top of that local land use information with a second stage of our model.
Mm-hmm. And then a couple of challenges to some of the work you described with the satellite remote sensing. How do you account for and measure exposures inside? We're talking about outdoor ambient levels, home, office, schools, where kids spend time. Temperature and air quality are different than the street outside.
Yeah, that's right. So we're measuring, ambient conditions if you were to step outside of your home. And so there's a couple things that are relevant there. One is that we know that the air pollution that's outside, much of that is going to get inside. So some of my work in Mexico City, we see that the homes in Mexico City, they're very open. That's the mechanism of ventilation, and so everything that's outside is getting in. There is considerable indoor pollution on top of that ambient that's coming in, right? If you're cooking inside your home, if there's someone smoking inside of your home, that's going to add to it. And our model that we can cover continents, we can't measure inside your house from space, and so we're going to miss some of that. But it's still a relevant measure, because we see strong relations to many population-level health outcomes, including cardiovascular deaths or hospitalizations for these sorts of health effects, asthma, et cetera. And ambient air pollution is something that is regulated and something that we can talk to our policymakers about changing. We know that some of our exposures are coming through long-range transport from major emitters. We know that some of them are coming from the combustion byproducts of the trucks, buses, and cars on our streets. So even though we're not getting at what's happening in the indoor environment, the ambient exposure is still relevant, it's important, it's associated with health outcomes, and it's something that we can regulate. We do work on studies where we also get additional measures inside the home, and we can layer that on top of what's happening outside of the home. But you know, I think that they're both very important. For temperature, I would say that you know, people vary in their ability to adapt to the temperatures that they're subjected to where they live. So one mechanism of adaptation is for extreme temperatures. Some people have air conditioning. Not everyone has air conditioning, and some people adapt physiologically, and that varies depending on your age and health status. And so we know that the health impacts of extreme temperatures vary substantially across the population, that there's susceptible subgroups, the very elderly, the very young, people who have other chronic health conditions. And so, you know, it's important to keep that in mind, and keep in mind individuals' capacity to buffer these sort of stressors, which is a kind of a theme that had come up. But you know, ambient temperature is a salient feature. It matters. It was really warm yesterday, and you know, I think we need to think about what are the relationships between those extreme temperature phenomena that we see and health outcomes across the life course.
And then another question relevant to that is, which we all struggle with as environmental health scientists, where you live often correlates with other things, right? Lifestyle, socioeconomic status, some things we showed had independent effects. How do you control for these factors to ensure that it's actually temperature or the air pollutants that you're measuring, that is more likely having the causal effect?
So I would say, yes, all of those factors are very important, and that was part of our discussion and introduction of the exposome, is we need to be considering the totality of these factors, and that those kinds of other things going on, they can relate to your susceptibility. So we don't have to think of it as an either or, right? It's a complex mixture. And Dr. Wright gave an example of how the association between air pollution and asthma was particularly seen among the children who had experienced these stressors. So I think we need to be, first off, measuring all of these factors. And then, so the question was sort of, how do you tease apart which one is the cause? And well, so we have statistical techniques. You know, I mentioned, for example, our studies on the acute effects of temperature. You can use each person as their own comparison. So it's an epidemiologic method known as a case crossover design. And so then, because each person is their own comparison, looking at the temperature in the days before their adverse event versus other days that are matched on the day of the week within the same month, for example, then that person being their own comparison, you don't have to worry about any sort of confounding by their individual level characteristics, anything that's not time varying, right? Because for each person, you're comparing them to themselves, right? So what are the odds that they would have had that event had there been a different pattern in the temperature or in the temperature variation or in the air pollution or any of these other temporally varying or spatiotemporally varying factors. So that's just an epidemiologic method that we can use. There's other epidemiologic methods that we can use to try and disentangle these things. But I think that the key point that you know, bad things often cluster together is a critical concept of environmental health, right? We're never exposed to one thing, and you know, we need to think about what is the impact of a mixture.
And that's more evidence of why the computational scientists need to be right along with us as we design our studies, we think about what we need to measure, and then how are we going to incorporate that into our analyses. And quite honestly, as these things march along, they have to be moving right along with us and developing new methods to accommodate the more and more things that we're putting into these models. And we've been, you know, tremendously lucky to have great statisticians join our team as well. So for Dr. Aurora, diagnosis of autism that's on the rise, and because a diagnosis of autism provides health and educational and support and funding advantages these days, and while other diagnoses have decreased, and maybe that we're seeing diagnostic bias.
So that,
I guess is what.
that's a good question, and that's been asked for quite a while now. There have been studies that have looked at the applied modern clinical diagnostic methods to older populations. And they confirm that, yes, some part of this there is something that's really happening. And they consider all these other factors too. The balance of evidence at present suggests, or not, well, strongly supports, that this is a real increase. It's not just a diagnostic bias.
And then another one is a bigger question. You showed you have an early marker of risk prior to clinical manifestation of autism. Can autism be cured? What is your goal with that? In other words, I think is what the question is, right? What do we do with that information?
So I'll answer the cure part with another question, because that entirely depends on your definition of cure. But our purpose in developing an early marker is this, and then you can decide whether this is cure or therapy. We know there are various psychobehavior therapies that do have a big impact. At present, we implement those therapies too late. We implement them at first clinical signs and first clinical diagnosis. And at very early stages of autism, especially if you're on the border, you can get different answers by going to different clinicians, because it's a tough thing to diagnose. There's no blood test for it. So many kids are missed at that early age. So my hope is that with a single sample collected early in life, I'm hoping before 6 months of age, that we can give a strong indicator of the risk of autism, and then we can start implementing all these therapies. What those therapies are, I'm not a psychologist, I'm not trained at all in that field, so I cannot answer that. But our job is to provide that information and then partner with those clinicians, and at the end of the day, if the answer is a pharmaceutical intervention, we'll help along those tracks as well. Because one of the strengths of what we find is that it's an environmental factor, and it's a physiologic factor that can be modified. We can't change your genes, but we can change your environment, and we can impact how the body deals with certain environmental stressors. So that's what we are aiming for. Whether that results in a complete reversal of the symptoms of autism is a very difficult question itself to structure. There's actually multiple questions there. So in that sense, we're not looking for a cure, but if we can minimize the impact of autism, that would be, I think, a big step forward.
And then I'll try to compile some of these together. The questions on stress, there were questions about studying adolescents, and do we have information on the significant rise in things like anxiety disorders in adolescents? Well, adolescents have many challenges, nothing more than that's been in the news in the last week with the Parkland High School shooting and the way that kids grow up and have to worry about different things and those kinds of things. Our cohorts are not focused on adolescents. Of course, our hope is that we follow them into adolescence, and some of our cohorts are getting to those stages where we can measure those more directly. Bob mentioned some larger national consortia we've become a part of, like ECHO, Environment and Child Health Outcomes. That spans the spectrum all the way into some cohorts that have been enrolled prenatally and now followed into adolescence and early adulthood. And we are going to be measuring some of those things, and certainly environmental influences are a factor there as well. So it will be a focus going forward for sure. One question asked, is the stress of the mother during pregnancy greater than or equal to the mother's childhood stress or her earlier life stress in predicting outcomes in the infant? Actually, you know, we're still trying to tease some of that apart. The key thing to remember, though, is there are independent effects of mom's stress that she carries in from her own lifetime, what she's experiencing right now during the pregnancy, and there's an interaction, actually, of those things that we're trying to sort out. And how can we best identify risks so that we can actually intervene? Another question asks that, are we considering other interventions like nutritional interventions? We didn't talk about it this year. I think that was part of our topic last year as well. Absolutely. Nutrition is another potential way that we can buffer the effects of the chemical toxins, but also the psychological stress toxins as well. And that's something that we'd like to grow here, is nutritional science in the context of the Exposome Institute. Other people asked about prednisone and steroid use, and does that actually have some implications for some of the stress work that we're doing? We know that that affects the hypothalamic pituitary adrenal axis, which produces cortisol in your own body. So if you're taking that exogenously, steroids either through a pill or inhaling it, it can affect the inhalation. You have to take quite a bit before you have an effect on that axis. In our data, we control for use of steroids for sure, because we want to know that it's the endogenous that we're measuring, that it's the effects of what mom's body is producing in the context of stress, or that child's body is producing in the context of stress. But that's a very important question. Here's a broader question. Somebody's concerned that the research is being negatively impacted by the funding for the research that we're all talking about in environmental science. How is it being negatively impacted, if at all, by the present administration in Washington or in New York State? Fortunately, I don't have any EPA funding, so my NIH funding hasn't been so impacted, but I know some folks who've had EPA funding have been a little bit more fun, and I don't know if anybody else wants to comment on that. And we've been fortunate, as we've shown, so we've been able to go on. And that's an important question to think about, as we've seen so many changes to the EPA and other agencies that are overlooking our environment. Just as the science is telling us, hey, environment is a critical part of what we're seeing with the rise in health outcomes, you know, we're all right to be concerned about that.
And I would say that there's two parts of that. One is funding science, which is how we develop an understanding of the relationships that we're talking about today. And then the other question is, how do we develop actions out of the science that emerges? And so we need government to both support the science and to play this key role in translating science into action when we're talking about regulatory paradigms. So that's an important part. So the concern has to do with both of those.
I know we're just a couple of minutes over, so can I do want to, we'll be here, and we're happy to answer any questions, and you can come up and ask some of these more directly of the people on the panel. A couple of things have come up. Are we thinking of measuring radiation? How does that, what do we know about that in child health and chronic disease? Cell phone, is the cell phone considered as a separate environmental factor? What do we think about things like social media and how that may play a role in stress and that we're talking about? These are things we're thinking about as well. These are all good questions. They're certainly a part of our environment, and when we're talking about young people in particular, they're part of our environment. So people may want to comment on any of those. Does anybody want to? Other than to say, these are things that are on our radar as well, but these are things that will need to be further developed, and hopefully you'll hear about in workshops and symposia going forward. The other thing, you know, we talked about lots of new methods that we're using. Someone asked about breathomics, so to measure, study potential use multi-gas analyzers to quantify interaction of inhaled external exposome with exhaled internal exposome. We think about that on a smaller scale in some of the research we're doing around asthma. So we use exhaled breath condensate to measure sort of some biological response to some of the chemical factors or stressors that we're thinking of. Things like inflammatory cytokines can be measured there, or things like oxidative stress markers. I know Roberto Lucchini has used that in his group cohort. Maria Rosa's interested in doing that as some of the respiratory work she's been doing in Mexico City, for example. We haven't done it and thought about it on an omics scale. I think the science, they're developing and going to have to validate those tools and standardizing, so what's the norms that we might counter what we measure against is a challenge there. And then here's one that I think we should address. How do we utilize your findings of adverse effects of environmental health in the city and state's environmental impacts reviews for new projects and toxic spills, et cetera? How do we, this is a translation question, right? How do we use the science to translate to some of the policies that are developing in response to things that happen in our own communities, right? If I paraphrase what the question is asking. What are the opportunities? How can we?
Well, I think that requires communication between the right groups, and also working with community groups, but working with policymakers. Our P30 Core Center does have a community engagement core, which Dr. Maida Galvez runs. So we are doing some of that work, working with some community groups like We Act, but obviously that's not going to cover the whole city, much less the state or the federal government. But these are things that I think require more engagement, more communication to really get out there. And that's something that we're working on, but it's difficult. You spend enormous amounts of time doing the research, trying to get the funding for the research, and there's a lot of demands on the scientists, and so I think these community engagement cores help in order to focus us. I sometimes think we lose. I think we sometimes lose why we're doing this, because deep down inside that is why we're doing this, and sometimes that gets lost. And I think it's important that we keep our eye on that, because that is the real reason why we're doing this work.
Okay, I know I'm respectful of everyone's time, and we're a few minutes past noon. I tried to get to most of all the questions and compile them together. If we didn't, please, we'll be here I think we're all able to stay for a few more minutes as well, and we're happy to answer more directed questions around the tooth biomarker or other things. There were a couple in here, I know. So feel free to come up. You can also contact us through the information that's in the brochure it's in the folder that you have, and we have the website, and feel free to always reach out as well with other questions. So thank you very much for coming, and thank the speakers. It was terrific for me to hear as well.